The vessel size is too small. It's hardly 2.5 max. It looks maximum 2.5 size. So again, distal disease. The patient itself is not a good patient. He's got peripheral arterial disease, significant peripheral arterial disease. So whether we should, yes. But there we thought probably debulking might be needed, but the lumen is quite big. So even if you do an OCT, you will see some nodules protruding there. If at all we go with an orbital, whether it's going to touch that particular nodule or just a balloon dilatation, not very sure about it. So that's so we thought probably we'll wire the LED, do something regarding that particular area, then because anyway you wouldn't want to get an OCT catheter or so into this particular area and all. So settle off with this particular lesion, manage this, then come back to the left main bifurcation and do a proper work over there. And that's what we had in the mind. Like, is tapering and narrow. It's a diffusely diseased vessel. Maybe the lumen appears to be reasonable, but if he didn't have these sort of lesions over here, we would have just opted for a medical management for him rather than. But if we had to do that distal lesion, then probably otherwise we destabilized all those particular areas. So that's what we'll do. We'll go femoral, and the radials are not good. Again, the left main ostium is not very roomy over here, so safer going femoral would be the ideal thing. The 5 minutes condition is starting off 5 minutes. Ready? Yeah? Okay. Can you see us, hear us? Can somebody pick the phone?
Yes, sir. Yes, sir. We can hear.
Okay. You have it. Not the phone, the mic. Okay. So, okay. So, we started off femoral 7 French guide catheter. We'll do couple of images, the caudal and cranial. Then be ready with the microcatheter, and run through wire. In New York, run through wire is needed. Okay, run through wire and microcatheter. Plan is okay. Anyway, we'll do take couple of images and then we'll decide on that. Caudal. Apicaudal, so that we can see the bifurcation and circumflex clearly. Okay. So do not pan. Centralize. Okay. Keep it there itself. So in fluoroscopy, the circumflex doesn't have much of calcification. Okay, that looks good. LED is flowing. Now come cranial. Little bit. Okay. Okay. Now, based on this, now what do you think? Proximally. Anyway, we'll have to do something for the distal LED. we'll wire, get the microcatheter. Vishnu, we'll wire that. We'll do an orbital atherectomy of the distal lesion, deploy a stent there, then image the proximal segment, and then decide what needs to be done for that. This is New York wire, right? New York. Huh? Give a New York wire. Because in case we are planning for a DK crush, probably the wire will keep moving here and there. You might find it difficult to push it across, so we'll go with a New York wire. The distal vessel, it looks 2.25, 2.5. So probably we can go with a 2.5 stent. But if you're going with a 2.5 38, then the second 38 may not cover. If at all we are planning to deploy a stent from the left main ostium to LAD, a second stent may not cover that. So probably what we'll do is we'll deploy a longer stent, a 48 millimeter stent, 48 millimeter, 2.5, 48, and then optimize the proximal segment. Vishnu, a tippum kuda unnu. Get an okay, in case we are planning the circumflex also, circumflex and LED by left main bifurcation, get another New York wire. Okay.
For distal, only balloon-based strategy is enough, sir. Because
Shall we, rather than going in for orbital, right?
yes, sir.
We'll okay. So one thing, Vishnu, shall we just without the microcatheter, shall we just wire that? Use a 2.5 millimeter balloon, dilate it, and see if it dilates. Probably we can avoid orbital. Yes, that's what we'll do.
Yes.
Because that calcium, it looks more of adventitial calcium, and again the please run that cranial view, and again whatever calcium we see is more in the area where we do not have a tight lesion.
Yes, and vessel size also.
Safety is to be given more of importance. We'll wire it, take a New York or a 2 balloon, ox 2 balloon. We'll try to dilate that. Okay, come cranial. We'll try to dilate with the 2 balloon. If you're able to dilate with the 2, transfer the epicranial image. Okay. If you're able to dilate with the 2 balloon, we'll dilate with the 2.5 and go ahead with the stent implantation. We are going with the 2 into 15, right? Okay. Be ready with the 2.5 also. $12, $14, $16. Yes. Negative. Yes. Okay. അത്രയും ഡിസ്റ്റൽ പോകണ്ട. Okay, okay, we'll dilate it there. $12 and $14. Negative. Okay. And 2.5 balloon and 2.5 48 stent. Okay. We'll come out. Yes, yes. After 2.5 dilatation. Yep. Yes. 14, 16, 18. 20, 22, 24, 26. Give another balloon. 22, 24, 26. Oh. Give another 2.5 balloon. അങ്കിളിന് ബുദ്ധിമുട്ട് എന്തെങ്കിലും ഉണ്ടോ? അങ്കിളെ, രാജു അങ്കിളെ, വിഷമമൊന്നും ഇല്ലല്ലോ? ഇല്ല. 2.5 into 15. 14, 16, 18. നെഗറ്റീവ്. അതെ. അയ്യോ ഇല്ല, കാലിന്റെ അല്ല, നമ്മളിപ്പോ ഹൃദയത്തിന്റെ അല്ലേ ചെയ്യുന്നേ. അയ്യോ അങ്കിളെ. Because of these multiple comorbidities, we were wondering whether we should go for the bifurcation or just settle down with this distance. Okay. Little proximal. Yes, we'll go there. So we are going at 12. Be ready with the stent. 12, 14, 16, 18, 20. It didn't open up well, but that's enough. It's a small vessel. We'll come back little more. There. 14, 16, 18. Yes, give the stent. It's not, the lesion is not fully prepared, but then I think we'll go with the stent. Now, post dilatation with 2.5 short balloon and 3 balloon. 2.5 and 3 balloon. And then followed by OCT pullback. Looks okay. Guide yes. We'll do a cine എടുത്ത് നോക്കാം. മതിയല്ലോ? മതിയല്ലോ? മതി. That's enough. 10, 12, 14. We'll be happy with this expansion at least. ഒരു അല്പ പുൾ ബാക്ക് ചെയ്ത് 16, 18. Okay. We'll pull back the wire also a little bit. 14, 16, and 18. Okay. Now give us 3 balloon. 2.5 and 3. Okay. 2.5 and 3. Yes. 14, 16, 18. We are going with a 2.5 for distal post dilatation, negative, yes. And then 3 proximal post dilatation. Then we'll do an OCT imaging from the left main to LAD and then decide what needs to be done for the circumflex left main LAD bifurcation.
So the distally opening was good, but the proximal part.
Yeah, proximal we dilate with 3 balloon.
3. Okay.
Post dilate with 3 balloon. Yes. Okay, position looks okay. 12, 14, 16, 18. Yes. Yes. കുറച്ചുകൂടെ distally will go. 18, little more distally. Yes. What Silakar? Ah. 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 10 milligram, slowly. Okay. Now we'll go with the 3 balloon. 18, 20. Okay. Okay. This is 3 into 10. Okay. 18, 20. Negative. So now we've taken a 310 for the proximal post dilatation. Saturation. Okay. We'll dilate it there and okay. Now we'll go at lower pressures. 10, 12. It's opened up. Okay. Okay. 14, 16. Okay. Wire tip. 14, 16, 18. It's open there. Okay. Okay. 14, 16, 18, 20, 22, 22, 24. It's open. Okay, negative. When it opens up like this, it's always good to have a small puff to make sure that there is no perforation. Okay. We'll pull back a little bit. No. The entire stent has been post dilated. Proximal. Proximal. Okay. Okay. Now we do an OCT run. 12, 14, 16, 18, 20. Okay, now anyway we are committed to do the left main bifurcation stenting. We'll take this out. We'll go with OCT pullback. Okay, now the stent appears to be reasonably well deployed. That opened up at 26 atmospheres. We were holding on at 26 for 2-3 seconds and it opened up. Yeah, Arya. Hello? Hello? മിണ്ടുന്നില്ല ആരും എം ഐ പ്രിപ്പയർ ചെയ്ത് വിട്ടോളാൻ പറ വി ഐ പി പേഷ്യൻറ്റിനെ എന്താണെന്ന് എന്നോട് കണക്ട് ചെയ്താൽ ഞാൻ സംസാരിക്കും. ഓക്കെ ഓക്കെ സോ വിൽ ഗോ വിത്ത് ദ we'll go with the OCT catheter. Get ready with the 20 cc catheter, 20 cc syringe. Okay, that's good. Fisheye. Okay. Yes, auto calibrate. Okay. Is this a New York catheter? OCT? Come closer. Yes, that's enough. That's enough. I think we'll image from there only. Vishnu, we don't have to go distally. Just make sure that the stent, that half of the stent is anyway opened up. Yeah. No. Okay. So we'll adjust the guide catheter. Okay, we are ready. Yes. Yes. Pressures are okay. Yes. Activate. Keep a watch on the saturation also. Okay. Now give us another wire for the circumflex. Give us another wire for the circumflex and also a 7.5 glove. Well, now we are seeing the left main here. We are seeing the circumflex and the proximal LED. The proximal LED appears to be too small. It's 2.4 millimeter. So probably something needs to be done for that. And when we come to the left main is 5.5, and there is significant calcification there. Luminal area is around 5 to 6. I think anyway, proximal LED also needs to be addressed. The circumflex also needs to be addressed. So we'll go ahead with a decay crush technique. We'll wire the circumflex, do an imaging from the circumflex, and then start balloon dilatation and deploy stent. Here it's all thin sheets of calcification, 360-degree arc of calcification. Did we dilate this area also? We have a fracture here. Much proximal. Did we post dilate proximal to the stent? I think we have post dilated somewhere proximal to the stent because we are seeing multiple areas of fractures.
Probably the calcium was looking like a stent.
Yeah, that's why we pulled it back and dilated. Inside the stented segment, there are multiple areas of cracks. Cracks seen. So those are the stented area, and proximally probably we would have post dilated these areas, hoping that that's the stented area.
Do we need debulking there, sir?
It's all very thin calcium, no? Yeah, in fact, the balloon, when we dilated in this particular area, did not open up well. So probably we'll go with a bigger balloon, probably 3.5.
Okay.
These should crack. These calcium should crack. It's not very thick calcium. It's almost 3.5 over here in the proximal LED.
Okay.
Here again, if you look at the vessel size, it's almost 3.5. Do not be aggressive. We shouldn't be going more than 3.5. So here again, in this particular area also, the prox LED appears to be 3.5 or little more than that. and the left main again 4.5. So we'll just take a quick pullback from the circumflex, and then we'll do balloon dilatations and deploy the stents. Again, the left main has got 180-degree arc of calcification, but then it should open on the other side at least.
But not more than 5 mm thickness, so we are going with.
Yes, it is more than 5 mm thick. This should come to almost 800, 900 microns. If you measure this, it would be almost 900 microns, 1 millimeter thick. But again, it's just a 1 quadrant or less than 2 quadrants, no? So probably wouldn't be an issue.
But in LED, everywhere it's less than 5 mm.
Yeah, it looks so. In LED, it's not a thick calcium. Yes. It's all thin ring of calcium. So that's probably the reason why we were able to dilate it with the balloon partially at least. I think you should give a New York wire to the circumflex. We have to cross, recross, cross, recross. So it's a New York wire. Okay. We'll keep it.
Length of LM.
Length up to LM. We'll go evaluate it once again, because the guide catheter is deep inside the area. From there. No, you have to measure the length. Yeah. Okay. Come more proximally, come more proximally, come more proximally, come into the guide catheter, at least 5 millimeter into the guide catheter. At least 5 millimeter. Come more proximally, more proximally, more proximally. Okay, leave it there. What about the other marker? No, the other marker, distal marker. We need to assess the length of the lesion area, length of the lesion. Green marker area. Green marker. Okay, there. Okay, so it's 28 millimeter. So 28 or 30, 33 we'll take, because we are not really seeing the ostium of the LED. So okay, we'll do a circ pullback also and give the OCT catheter, and then we'll dilate with a 3.5 balloon in the LED and a 3 balloon in the circumflex. 3.5 and 3.25 in the LED and 3 in the circumflex, and then a stent 3 into 23 to the circumflex.
Planning DK crush or mini crush?
We mostly here we try to do DK crush. Mini crush we never do. At times tap. Culotte is very rare. Mini crush, technically it is much more simpler. Hello? 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 Okay.
Activate.
When we'll the circumflex wire also, we'll pull it back little bit. We'll take out the OCT catheter, pull back the circumflex wire, give a balloon for the circumflex. That is, this would be a reasonable landing zone there. So there the vessel size is almost 3. The vessel size is almost 3. So we'll take a 3 balloon for pre-dilatation of circumflex. Arya give a 3 balloon. There is no much of calcium. There are islands of calcification, but it's more a fibrotic plaque. Now, one quadrant of calcium is seen. We have reached the left main. So inside the circumflex, there is some calcium, but it's all no concentric rings of calcification seen there. That is what we fluoroscopically also expected. So again here the stent length would be somewhere from here till the left main would be 18 or 23. I think we prefer 23. We go for 323 stent from in the circumflex. Prior to that, we'll do the balloon dilatation. Three balloon for the circumflex. Yes, that's what I think we have taken it for LED pre-dilatation, post-dilatation. Vishnu, we'll go into the circumflex and dilate it. And then a 3.25 balloon for dilating LED. Yes, 8 or 10. Because 8 or at least we need 12 because we need to use that as a crushing balloon. So we need at least 12 length, because if you take a 8 millimeter balloon for the crushing, it will melon seed. So 3.25, 12. OCT wise, we felt that the proximal LED is 3.5. So then the pre-dilatation, we don't have to do it with a 3.5. We try to do it with a 3.25. Okay. Okay, Mali, dilate. Negative, melons. Okay. 12, 14, 16, 18. Negative. 18. Again 18. Negative. Alpha could have pulled back with nil once. Okay. Once again 18. Yes. Yes. Okay. Small test. Now get the 3.25 balloon. We'll take this out and then okay. Okay. 3.25 balloon for LED and be ready with a 3.3 and do 3 into 23 for the stent. In the circumflex elevation. In the circle, eh? This is circle, that's LED. Okay. 3.25 into 12 for LED. Always when we use a crushing balloon, it's always better to go with a longer balloon, not very long, because if you use a 8 millimeter balloon while doing this crushing and all, the balloon can move this side or the other side. If it comes proximally into the left main, we'll find it extremely difficult to again further negotiate it into the across that protruding strut into the distal vessel. So it's always good to have little longer balloon rather than having an 8 millimeter balloon. 14, 16, 18, negative. Stent 18, 20, yes, 18, 20, negative. Now I think it has opened up reasonably well because it was more of thin calcium.
Yes, sir.
12. Give the stent. Negative, negative. Creatine is all right, isn't it?
So for crushing, you have to choose the size based on the distal. Sorry.
The first crush, yeah. The first crush has to be based on the distal vessel size. A 3.5 balloon. Here we have opted for a 3.25. Now for the second crush, If 4.5 would be preferable for something that is size for the left main.
Okay, sir.
Be ready with a 4.5 balloon also. And Angel, okay. Be ready with a 4.5 balloon. This position seems reasonable. Okay, we'll deploy the stent in the circumflex first. Okay, Vishnu, 12 atmospheres, stent, 12, negative, 14, 16, 14, 16 and 18, negative. Now we'll pull back the other balloon. Okay, 14, 16, 18, 20, negative. Then we'll take out the wire, make sure that the circumflex is flowing well. Take out the wire from the circumflex and once again dilate it. Okay, we'll take out the wire from the circumflex. Okay, once again crush it, 14, 16, 18. Contrast, okay. Negative. Okay, now we'll take out these balloons. Okay, be ready with the OCT catheter. We have taken out both the balloons. Now we'll rewire the circumflex and then do an OCT pullback. Okay, we'll have a OCT pullback now. Be ready with 1.5 balloon. OCT catheter. Just to make sure that the crossing is not very distal. Fluoroscopically, it's not a distal crossing. Then 1.5 millimeter balloon, 2 balloon and 3 balloon. If it's a very huge left main, probably it's always good to again further do a second crush which is sized to the left main with a 4.5 balloon. Okay, now we'll take an OCT pullback. Okay, ready? Yes. Yes. Here we'll take a very short pullback. It's going to be just 5 ml. Yes. Yes. Okay, once again we did. Okay, once again we'll go. Before I started injecting. Yes. Okay, we'll come back. Okay, we've reached the resting position. Okay, once again. Ready? Yeah. Okay. Yes. Yes. Activate. Okay. Now show the bifurcation in the longitudinal mode as well as the 3D bifurcation. 1.5 balloon. Yes. Arya, rotate and show the circumflex ostium. Okay, now we are seeing the circumflex ostium. I hope you can see. Can you? Okay, are you seeing the longitudinal image?
Yes, sir.
Okay, so this is the circumflex ostium. We are seeing couple of struts over here, and we need to have a more proximal crossing. Now you can see that the wire is going into through the more proximal cell into the side branch. This again can be made out in the 3D bifurcation mode also. You won't be able to see the stent rendering when you do a crush, primarily because you do not have much of metal inside the main vessel. Because you do not have much of metal inside the main vessel, you won't see the stent rendering, but then mostly you'll be able to see this sort of ghost image of the stent. Can you? I hope you can appreciate that.
Yes.
These are the crushed stents, and this is the proximal cell, and this is the distal cell. The wire has gone through the proximal cell. Now we'll dilate with 1.5 balloon, 2 balloon, 3 balloon, and do the kissing. What is 7 point? Arya, can you again show that longitudinal view and show us that the stent crush is good? No, not this. Rotate it. Show the circumflex ostium clearly. Come down. Rotate it once again. 180 degree. 180 degree. Rotate, 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 rotate. Okay, okay. Now we are seeing the circumflex. Now, are we seeing any struts floating in the left main? In the 2D image, not in the 3D image. In the 2D, down there. I didn't know. Okay, down there.
Yes.
Rotate and show whether we are seeing 2 layers. We shouldn't be seeing. Okay. Ponilla. Give another 1.5 balloon. I'll come. Okay, this is 1.5 balloon. Then 12, 14. Negative. If you're planning to do, if you're working with a 2 millimeter balloon and a New York balloon, you can straight away go with a 2 millimeter balloon. Here we are trying to do with an ox balloon, so 1.5. We'll go ahead. 12, 14, 16. Now give a 2 balloon initially that we have taken. Okay, negative. Okay, 2 balloon, then a 3 balloon. Two balloon. Yes. 12, 14. Next a 3 balloon. Negative. Okay, 14, 16. Now a 3 balloon. Negative. The 3 balloon that we have taken earlier for pre-dilatation. 310. And then a 3.5 to the LED. 3.5 balloon to the LED. And in case the 3.5 doesn't cross, get ready with a New York balloon. 14, 16. Negative. Okay. Now we'll have a 3.5 for the LED. 3.58 is not enough. We always need, for kissing, always need a longer balloon, because otherwise this will melon seat. Anyway, we'll go with that. But always 12. Ari, അതെന്ത് ചെറുതെടുത്തു തന്നെ? Negative. Okay, now be ready with the next stent. Left main to LED, 3.5 into 28 or 33.
33, because it
That,
was sometimes.
yeah, it was, the guide was inside the left main.
Yes, sir.
Oh no, it's not going. So give another New York one. Yes. അല്ല മേലത്തെ ഓക്കെ വേറെ ആരുടെയും നമ്പറിൽ ജോജോയുടെയോ മറ്റോ അയക്കാൻ പറ. ഓക്കെ, now we'll go for a 3.5 into 12 in LED. This is a New York one. Yes. LED balloon. Who is having LED? Mali, have the LED balloon. Okay, dilate LED balloon. 12, 14. 12, 14. 16. Negative. Again the LED balloon. Once again, I'll tell you. Okay, 14, 16. 18, 20. Negative. Now we'll post dilate the circumflex. Okay, there. Okay, 14, 16, 18.
16, 18.
Negative. We'll again post dilate the circumflex ostia at 22. 22. Negative. Now we'll take both the balloons to 8 and 10. Once again, just hold on. Okay, 8. 8. 10. Negative. Okay, now the next stent. 3.5, 33. Yes. We'll give 2.5. ഏത് പേഷ്യൻ്റെ കാര്യമാണെന്ന് പ്രിപ്പയർ ചെയ്ത് വിടാൻ പറഞ്ഞാൽ. Now we'll go with the next stent. It appears to be good. The circumflex ostia appears to be good, and we have a dissection in the LED because of the 3.5 dilatation. So now we are going with the next stent from the left main ostium into LED. By the time we deploy this, we'll take out the wire from the circumflex artery. Okay, now come cranial. Get ready with a 4.5 balloon. Show the ostium clearly. tilt the table and show the ostium. Okay, okay. That appears to be okay, Vishnu. Okay, we'll go up. 12. 14. 14. Okay, negative. Now come caudal. We'll see the circumflex ostium. Okay, that looks good. Now we'll disengage the guide catheter a little bit, push the wire into the aorta, and then take out the balloon. Now 4.5 balloon. Yes. Negative. 4.5 into 8, and then we'll recross into the circumflex, do an OCT pullback, then 1.5 balloon, 2 balloon, and 3 balloon. Okay, 14, 16. 14, 16. Negative. 16, 18. 8 melon seed negative. I think we'll pull it back little more once again. Okay, so okay. 16 negative. Unless we push the wire into the aortic root, this balloon, when we take it out, it will deform the wire that's positioned inside the guide catheter. So it's better to push it into the aortic root. Torque. Get the OCT catheter ready. This crossing, we would prefer to have it the more distal crossing if at all possible. It seems to be too distal across, okay, I think we'll do an OCT pullback and then decide. If it is too distal a crossing, you might find it difficult to get the 1.52 millimeter next balloons into the circumflex. Now next 1.5 balloon. Okay. Are we ready? short OCT pullback.
This is to see the wire cross.
Yes, yes, just to see the wire crossing. Okay, ready? That's usually less than 10 cc con. Yes.
Sir, during routine procedures like bifurcation,
Activate. Yeah.
do you confirm it all the time with OCT for the recrossed head?
For almost always, if it's left main bifurcation, but if it's LED D1, we usually do not do that.
Okay.
And again, if the patient is sick,
Yes, sir.
borderline blood pressures, we don't inject contrast that way. Here now the BP is good. That's the reason. 1.5 balloon. Arya shows the circumflex ostium. Remove the stent. Remove the stent. Okay, now the circumflex ostium, and show the wire crossing into the circumflex. Show the circumflex ostium down there. Down. Rotate, 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 rotate. Rotate it some more. Okay, okay. ഇയാൾ വീണ്ടും കറങ്ങി പോവാണ്. Show, rotate it little bit here and there and show the wire crossing. Okay, Vishnu, we will go with 1.5. I will show that. Okay. Martha. Now if you look at the longitudinal view, you can see here that this is the circumflex ostium. The wire has gone through the most distal cell. We'll try to go with the balloon into that. If it doesn't go through that, we'll try to take it out and wire it more proximally. Again, we can see that. I hope you can see the wire going through the most distal cell, right? The advantage of going through the most distal cell is you wouldn't have a neocarina at the end of the procedure. So we'll see the bifurcation mode also. In the bifurcation mode, you can see that the wire has gone through the at times the reconstruction doesn't happen properly. This is a computer generated image. At times it doesn't happen properly. You're not seeing the wire going into the side branch clearly. But once you remove the rendered stent and look at the longitudinal image, you can clearly see that it's gone through the most distal cell. I hope you can see that. Did the wire go? Did the balloon go? It's crossed. 1.5 is crossed.
Sir, okay. We could see that the distaling.
Pardon me?
Yeah, we could see that.
Yeah, yeah. Okay, the 1.5 balloon has crossed. Now 2 balloon. Show the angio image, fluoro image. Two balloon, 3 balloon. Fluoro, okay. Okay, we have dilated with 1.5 balloon. Now we are going with 2 balloon, and then the 3 and a 3.5 to LED for kissing. This is what, but 1.5 went in without difficulty, right? Okay, okay, 14, 16, 18. Now the 3 balloon. There is no ruptured balloon, it's ruptured, negative. Did really rupture? We'll just try to dilate it and see. Okay, it's dilated 12, 14. It is ruptured here at the proximal end. Okay, give us another 2 balloon. We are again going with a 2 balloon, 12, 14, and after that a 3 balloon into the circumflex. If it fails to go, we'll go with a New York balloon and a 3.5 aux into the LAD. Negative. Okay, 14, 16. Now 3.5 to LAD, 14, 16, negative. 3.5 to LAD and 3 New York to the circumflex. Yes. .5 to LAD. A 3 ആണ്. We will go with the 3.5 into LAD, the aux 1. 3.5, 12. Okay. 12. Negative. No, we need a New York one. Okay. There is some intertwining. Okay, New York wire, New York balloon. Okay, give the New York balloon into the circumflex. The 3 1. Yes. Give the 3. Don't disconnect that. Okay, we have gone with the 3 into the circumflex. Now 3.5 into LAD. Be ready with a New York balloon to LAD if it doesn't go through. Okay, so now we dilate the LED balloon, Merli LED. LED balloon at 14, 16 atmospheres, 14, 16, negative, 14, 16, yes, negative, 18, negative. Now we'll dilate the circumflex balloon at 18 atmospheres, 20, 22, 22, negative. Now we'll go both together at 8 and 10, 8 and 10. negative. Now the 4.5 balloon. Okay. 4.5 balloon. Mali valikille. I think we take this up.
balloon.
4.5 and OCT catheter. For 0.58.
So for the point of confluence, we need to go with some lower size and come at final part with 4.5 or
better not to touch at the confluence. We'll stay away from the confluence because anyway we have post dilated it very well. With the kissing balloons also we have redistributed it 12 and negative. We have redistributed the struts at the carina, and we are sure that because we had a very distal crossing the second time, we wouldn't have any metal at the carina.
Okay.
Yeah. So it's even if you expect, it's always safe. Here we do not expect any metal at the carina, but then if you have a proximal crossing and if you expect some amount of metal at the carina, still in that situation it's always better to stay very far away from the carina. Okay, we'll go. 12, 14, 16, negative. Now we are away from the carina. We'll do one more dilatation and stop with that. Okay. 12, 14, 16, negative. OCT catheter.
To look the ostium of left main, do we need to use that Nipro catheter as a transparent catheter?
No, Nipro is not transparent, only the telescope.
Yes,
telescope. That you can see only the most distal 2 millimeters.
Okay.
That 2 millimeters alone is transparent, but then doesn't make huge difference. We'll pull back the guide catheter and position right the ostium and see that. Joel, cranial. Okay. Ready? Okay. Yes, yes. Yes. Activate. Rotate and show the circumflex ostium also. Freeze. Rotate, freeze, and show the circumflex ostium. Remove the stent. Okay, show the circumflex ostium. Rotate and show the circumflex ostium. Yes, keep rotating, 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 keep okay, okay. Keep rotating. proximally somewhere near the ostium. We have reached almost till the ostium. There the stent is well expanded, 13, 14, 12. The confluence alone looks very small.
Looks like elliptical.
Well, this is the circumflex. The confluence is only almost 8. As we come more distally, this is the circumflex ostium. That area, the left LED stent, we have gone up to 16 atmospheres or so. The LED looks good, 3. It's almost that area. It is almost 5. Almost 5 where we have the overlap of stents. And as we come proximally, it is 7, 8 or so.
In that 5 area, do we need some more expansion, sir?
In the mid LED.
Yes, sir.
Oh, Vishnu? Well, this is the circumflex ostium, mid LED alone. Whether we need to post dilate it. We didn't have a rendered stent. We didn't have a angiocore registration, is it?
Seems that overlapping portion, isn't it, sir?
Yeah, that area. Here, this area.
Yes, sir.
This is the area where we had that under expansion 4.6, 4.6. But as we go distally, again, it's almost 5, 4.9 only. Should we really need to, at the area of the diagonal, that's the area where we have it around 4.5. Again, anything above 4, probably we can accept it at that particular area. But what I thought was the left main confluence was looking small. But if at all we were to dilate it, we have gone at the ostial circumflex at 22, 20, 22 or so. We have gone at the ostial LED at least 18 to 20. I think probably we'll accept it.
Yes, sir.
Nitro, we'll take final shoot. Caudal and cranial. Arya, caudal and cranial. Switch it. Angiographically, it's quite gratifying,
Yes,
but then in the anyway cranial view, it may not be gratifying. It might be it's actually an eccentric looking confluence. കുറച്ചുകൂടെ എടുത്തേക്കാം ഇൻ ടു ദ ഗൈഡ് എത്തിയിട്ട് അല്ലെങ്കിൽ നമുക്ക് ഇമേജ് കിട്ടത്തില്ല നേരെ കിട്ടത്തില്ല പുറത്ത് വരട്ടെ ഓക്കെ ഓക്കെ Yeah, here in this view the confluence looks small, but I think we'll call it a day.
yes, sir. Extensive.
Yes, yes. Enough.